Okay, everyone. So we will be finishing up the bones today. And just to review, remember we have the axial skeleton and appendicular skeleton. The axial skeleton is everything you see highlighted here in the center, right? And then everything outside of that is the appendicular skeleton. So what we already covered, the upper extremity, we did the two clavicles, the two scapulas, the two humerus, the radius, the ulna, the carpal bones, the metacarpals, and the phalanges. And remember, the phalanges had proximal, middle, and distal for digits 2, 3, 4, and 5, but the thumb, digit 1, only had a proximal and distal phalange. We are going to look at the lower extremity today, and we'll start with the os coxa, known as the hip bone. That you see we have two of them. Sometimes it's referred to as the innominate bone, meaning no name, innominate. We'll then move down to the two femurs, the longest bones in the body. Then we'll move down in the leg. We have the larger and thicker tibia, and then the thinner fibula. And then in the foot, we'll do the 7 tarsals, and then we'll do the phalanges. One of the things I want to point out, if you look at the orientation of the arm and the forearm, and we compare it to the uh, hip and the leg, right, or the thigh and the leg, if you look at the forearm with the radius and the ulnar, that would somewhat be analogous to the orientation of the lower leg, tibia and fibula. Um, One of the other things that I want to point out to you is that when you look at flexion of the elbow, right, when the elbow flexes, your forearm and hands move anterior, right? But when you flex the lower leg, it goes posterior. And that's because embryologically, what happens when you're in the womb, the entire lower extremity starts out the same direction that the elbow is the same positioning of the knee until the knee medially rotates. And when it fully medially rotates during development, the back of the knee becomes the front and the front becomes the back. So that's why you get flexion that happen in both in the sagittal plane, but in opposite directions. Flexion is this way forward, but flexion of the knee goes backwards, right? Keep that in mind. All right, so let's look at the first set of bones here. Let's look at the innominate bone, or one of the os coxa. And when we're looking at it from the lateral view, right, from the outside in, we could see the bowl, right, the deep vinegar bowl. This deep vinegar bowl is the acetabulum. You can see it down here, acetabulum. That's the ball and socket joint. But it forms from the ankylosing, or the fusion of 3 bones: the ilium, which is the largest, the pubic bone, and the ischium. So those 3 bones embryologically come together, they fuse, they ankylose, right? They stick together. And when they ankylose, they form this bowl in the center called the acetabulum. So if you could see the acetabulum, you're looking at it from the outer view, and that's where the head of the femur is going to fit to form the ball and socket joint. Much more stable than the glenohumeral joint. Why? Because this is a weight-bearing joint. The shoulder joint is not. So in comparison to shoulder injuries, to hip injuries, the shoulder can dislocate much more frequently and commonly than does the acetabulofemoral joint. Okay. Pubic bone is more anterior, right? Pubic, pubis, and then the ischium, this is what you're sitting on. This part right here is called the ischial tuberosity, and that's your sit bone, because that's what makes contact with the chair when you're sitting. Okay, so now let's look at the actual bone. And we can point out some landmarks here that I think are of significance and importance. So we already covered the name of this bone is the ilium. This is the acetabulum. In the front is the pubic bone. And there's a little bump there called a pubic tubercle. Right? Yes, you can see it on both views here. This is the ischial tuberosity. Now, what's the significance of the ischial tuberosity? It's really important. The ischial tuberosity, which is part of the ischium, is where your hamstring muscles originate. So your hamstrings originate here. This is why when there's a hamstring pull, people typically grab the back of the buttocks, right? They go, oh, right? That's where it tends to tear or pull off of this bone. Another important landmark is the top of the ilium. It's called the iliac crest. This is the iliac crest. Now, finding the pubic bone and the pubic tubercle is important because once you find that, that's anterior, which means up here, this is anterior, and here, this has to be posterior. So here's the iliac crest. Now, when you follow the iliac crest anteriorly, it takes you to a landmark that's called the ASIS, the anterior superior iliac spine. Now, if there's an anterior superior iliac spine, there's going to be an anterior inferior iliac spine, which is this one. So you have this bump and this bump, anterior superior iliac spine, anterior inferior iliac spine. The ASIS is important because that is a major landmark for where your sartorius muscle will originate. The sartorius is the longest muscle in the body. The AIIS, the anterior inferior iliac spine, is an important landmark because that's where the rectus femoris muscle originates. Your rectus femoris is one of your 4 quadricep muscles. The 4 quadricep muscles, of the 4, 3 of them have the name vastus in it. So there's a vastus lateralis, a vastus lateralis, a vastus intermedius, and the 4th is the rectus femoris. So the rectus femoris of the 4 is the only quadricep muscle, the immense muscles of the front thigh, that cross 2 joints, the knee and the hip. And the reason why it crosses the hip is because the rectus femoris originates right there on the AIIS, the anterior inferior iliac spine. Remember, on exams, you can't abbreviate, you have to write the full thing out. Now, if there's an anterior superior iliac spine and an anterior inferior iliac spine, we're going to have the same thing on the posterior side. So there's a posterior superior iliac spine, and then there's a posterior inferior iliac spine. So the key landmark there is the iliac crest. Once you find the iliac crest, if you go anterior, it takes you to the anterior superior iliac spine. If you go posterior, posterior superior iliac spine. And then when you drop inferiorly on either side, then it takes you to either the posterior inferior iliac spine or the anterior inferior iliac spine. Okay, moving on. On the posterior side, you're going to see a little bump back here. So here's the ischial tuberosity, and just above it, there's a little bump, and I'm going to explain the significance of that little bump. This little bump is the ischial spine. So the larger one that's rougher is the ischial tuberosity, and then the smaller little bump right here is the ischial spine. The significance of the ischial spine is that it separates 2 notches. It separates this notch, the greater sciatic notch, from this notch, the lesser sciatic notch. So you have a greater sciatic notch up here, and below the ischial spine, a lesser sciatic notch. And guess what travels through the greater and lesser sciatic notch? The sciatic nerve, of course. Okay, let's look at the same structure, but now from the anterior view. How do we know we're looking at it from the anterior? Well, when you're looking at it from the posterior and lateral view, you can see the acetabula fossa. But when you're looking at it from the anterior view and medial to lateral, inside to out, you don't see the acetabulum. Oh, you can see the large hole here and here. That's the obturator foramen. That's the largest hole we have in the body, called the obturator foramen. This smooth depression on the medial aspect of the ilium is called the iliac fossa. The significance of the iliac fossa, this entire smooth depression here, there's a powerful hip flexor muscle that originates there called the iliacus. It's called the iliacus. Okay, other than that, same structures. We can see the greater sciatic notch here. We see the ischial spine, and then we see the lesser sciatic notch. Here's the ischial tuberosity. Here's the pubic bone. And right in the middle is where the vertical fibrocartilage called the pubic symphysis, right? The pubic symphysis, the location of the pubic symphysis would sit right here. Okay, this is the ischial bone. This is the ramus, the ischial ramus. Okay, that's all the structures that we need to see from this view. Let's move down. Again, you can see the three major parts: ilium, pubis, and ischium. This is the obturator foramen. Here's the acetabulum. Nothing new here, all the same structures. If it's listed here and I didn't go over it, it means you're not accountable for it. When we look at it from the anterior view, let me just see if I'm going to have another. Yeah, so let me just zoom in here. Okay, so here's the iliac crest. Right here is the anterior superior iliac spine. And then right here would be the anterior inferior iliac spine. Same thing here, iliac crest, anterior superior iliac spine, anterior inferior iliac spine. Here's the pubic symphysis. Here's your sacrum. Here's your sacroiliac joint, is this line right here. That's your SI joint or sacroiliac joint. When we look at the pelvis from the anterior, here is your pubic bone. Here is your ischium. There's your pubic tubercle. Here's your other pubic tubercle. And then there's the pubic symphysis. That's fibrocartilage. It's the strongest cartilage in the body. Here is your obturator foramen on both sides and the acetabulum. When we look at it from the posterior, here's the iliac crest. We follow it around this way to the posterior, and then there's your posterior superior iliac spine. We drop down, posterior inferior iliac spine. Now the PSIS, the posterior superior iliac spine, this is pretty clear to see. If you ever see people at the pool or at a beach and they're wearing a bathing suit and the bathing suit drops a little bit below waistline, you could typically see these dimples, right? At the area where you see the dimples, that's where the posterior superior iliac spine and the sacroiliac joint come together. That dip or that depression is made from the large PSIS and then the little indentation of the sacroiliac joint. And it's also typically at the same level as S2 or the second sacral tubercle and the second sacral foramina, right? Here's the S1 foramina, here's the S2, S3, S4 foramina. Through these sacral foramina are going to be sacral nerves. Here's your coccyx that has anywhere from 3 to 5 fused segments. Here's the ischial tuberosity, where your hamstrings originate. Here's your ischial spine. We said that separates the greater sciatic notch from the lesser sciatic notch. The top of the iliac crest, if we follow it, takes us right around to the L5 vertebra, or at least the L4, L5 interspace, right? The top of the iliac crest is what we call your waistline. It's where the top of the belt is, belt line. And again, from the anterior view, you could see the L5 vertebra and the top of the iliac crest are in alignment. Okay, again, same structures. Here's your sacroiliac joint. Here's your iliac crest. Here's your iliac fossa. Here's the acetabulum, obturator foramen, pubic tubercle, ilium, pubis, ischium. The inferior part is the ischial tuberosity. You don't have to worry about the arcuate line. Your greater sciatic notch, ischial spine, ischial tube, lesser sciatic notches down here, coccyx. Here's the sacral hiatus, right? It's just this non-union or this gap where the median sacral crest is. Posterior superior iliac spine, posterior inferior iliac spine. The only thing I wanted to show you here is comparison left to right. This is how archaeologists, when they find bones, right, they try and decipher based on the weight, based on the size, based on the orientation. How do they know if it's a biological male or a biological female bone? Well, if you look at the line between the um, if you form like an imaginary line where the pubic symphysis is, right? This looks like um, this could be like a champagne glass, right? This looks like a margarita or like a wine, right? So one is wider, one is smaller angle here. So the wider angle, think of a baby being able to pass through here. That's the female. The shorter angle, 90 degrees or less, that's the male. 100 degrees or more, that is the female pelvis. Moving down to the longest bone in the body, let's take a look at the femur. When we're looking at the femur, let's start proximally on the anterior side. Here is the head. At the proximal part of the head, right here, there's a little indentation, a small little cavity called the fovea capitis. It's an important site because there's a ligament called the ligament teres that goes from the fovea capitis to the deepest part of the acetabulum, and it helps to stabilize that joint. So that's called the fovea capitis. Then you have the femoral head, you have the femoral neck, then there's a greater trochanter and a lesser trochanter. Remember, on the femur, there was, on the humerus, there was a lesser and greater tubercle. On the femur, there's a greater and lesser trochanter. Connecting the greater and lesser trochanter on the anterior side is the Intertrochanteric Line, but on the posterior side, there's the Intertrochanteric Crest. But the concept is the same. They are connecting the greater trochanter to the lesser trochanter. Greater trochanter to the lesser trochanter. Then you have the diaphysis, which is the shaft of the femur. When we move further down, you can see that there's a difference between the anterior surface of the distal femur and the posterior. On the posterior side, you can really see the rounded condyles, right? You could see the lateral condyle and the medial condyle. They're really rounded, right? A little bit tougher to see, but you can see the lateral and medial condyle from the anterior. Here is the patellar surface. The patellar surface is for the sesamoid bone or the kneecap called the patella to articulate with that. And then here's the intercondylar fossa right here between the two. At the deepest part of this depression is the intercondylar fossa. There is an adductor tubercle on the medial side, and above the medial epicondyle. So you have the condyles lower, epicondyles higher, and above the medial epicondyle is the adductor tubercle. That's where your adductor magnus is going to insert. So there are three large adductor muscles that we'll cover: the adductor longus, adductor brevis, and adductor magnus. And the adductor tubercle is just a prominent attachment point. So the reason why we're covering these bones again in these major landmarks is we're going to see them again when we cover muscles. So I'm presenting some of the concepts now, so it'll be a little bit repetitious when we cover the muscles. Also notice that if you look at the angulation of the femur from lateral to medial, it really does move medially, and it does so more in the female than it does in a male femur due to the wider hip orientation. So again, if we're just isolating it, femoral head, femoral neck, greater and lesser trochanter, here's the intertrochanteric line. When you see the intertrochanteric line, it's anterior. Also notice it looks different distally. Medial and lateral condyle, lateral and medial epicondyle, adductor tubercle. On the posterior side, same structures, but you can see the fovea capitis a little bit better, head of the femur, neck, greater and lesser trochanter with the intertrochanteric crest. The linea aspera. On the posterior side, there's a sharp line called the linea aspera. You don't see this sharp ridge on the anterior. So that's one of the key delineating factors of are you looking at it from a front or back. When you feel the texture of the femur, the posterior side has this sharp knife-like ridge called the linea aspera. And that's going to be one of the attachment sites and origin sites of the quadriceps. Okay, the back of the knee is called the popliteal surface. Again, lateral and medial condyle, lateral and medial epicondyle. Epi means above, and then above the medial epicondyle is the adductor tubercle. Here's the patella. Difference between the anterior patella and the posterior. The posterior is the articulating surface with the femur. The anterior side is rougher. It's not as shiny and smooth as the back. The reason why the front or anterior aspect is rougher, because there's going to be muscles and tendons that attach there, especially the quadricep muscles. The base is the top. The apex or the point is on the bottom, right? Most people think a mountain, right? The apex is the top and the base is the bottom. The base just means the widest part. So this is the widest part. This is the apex, the point. When we move down and we look at the lower leg, tibia and fibula, just remember you tell a small fib. So if you're telling a small fib, the fibula is the smaller bone, the tibia is the larger bone. These two structures, this bump and this bump, are in the same horizontal plane. This is the tibial tubercle. This is the head of the fibula, but they connect and they make a perfectly horizontal line. So the tibial tubercle or tibial tuberosity and head of the fibula make the same horizontal plane. The tibial condyle, this is the lateral tibial condyle, the medial tibial condyle. And again, you could see it from the posterior here, medial tibial and lateral. As we move down, the front of the tibia has an anterior margin that's pretty sharp. It's sharp and it's knife-like, pretty sharp ridge. You can feel it on yourself, and that's why it hurts so much when you get kicked in the shin, because there's really not much cushioning there. It's muscle getting jammed up and nerves and arteries getting jammed up by the sharp bone, the anterior margin. Now, two key structures when we look down at the ankle are the medial and lateral malleolus. So the bumps that you feel on the inside and outside of your ankle are made by the medial and lateral malleolus. Now it's a little bit clearer to see on the posterior view. I want you to notice that the fibula descends further distally. It goes down more than the tibia does. And the reason that the fibula descends further distally, right, the lateral malleolus comes down more than the medial malleolus, you can do this now with your feet, right? If you put your feet on the floor and you try and roll your ankles in, and then put your feet on the floor and try and roll your ankles out. The one that's easier to do is rolling your ankles in. The harder one is trying to bring the inside of your feet together, rolling your ankles out. And the reason being, the lateral malleolus, which is lateral, is blocking that eversion. Inversion is much easier. And that's why when you slip down the steps or you slip down a curb, the plantar flexion and inversion injuries are most common. And that's when you turn all black and blue and swollen on the outer part of the ankle because all those ligaments and tendons get torn. Okay, so tibia, fibula, the lateral tibial condyle, medial tibial condyle, tibial tuberosity or tibial tubercle, head of the fibula, and then if you go distally, lateral malleolus, medial malleolus. And right here in this gap, right here in this space, that's where one of your tarsal bones is going to attach. And that's called the talus bone. And that's what's going to make your ankle work like a hinge, like to dorsiflex and plantar flex, is the junction of the talus with these two bones. And this kind of looks like a monkey wrench, like an upside down monkey wrench. Okay, let's look again. Lateral and medial tibial condyle, tibial tubercle or tibial tuberosity, head of the fibula, anterior margin, tibia, fibula, lateral and medial malleolus. When we look at it from the posterior view, it's much easier to see the lateral malleolus descend further distally than does the medial malleolus. Okay, and now we're left with the foot. So this point right here, this junction between the lateral and medial malleolus is going to clasp this bone, which is the most superior bone called the talus. The talus is the highest bone superior, and the calcaneus is the most inferior. It's your heel bone. The calcaneus is your heel. Then you have the talus. Anterior to the talus is the navicular, and then anterior to the navicular are three cuneiform bones. It's called the medial, lateral, and intermediate cuneiform, or cuneiform 1, cuneiform 2, cuneiform 3. They're both interchangeable. So you have the talus, calcaneus, navicular, cuneiform 1, cuneiform 2, cuneiform 3, also known as the medial cuneiform, intermediate cuneiform, or lateral cuneiform. And then lateral to the lateral cuneiform is a cuboid bone. The cuboid bone articulates with the navicular, the lateral cuneiform, and the talus. And the cuboid also articulates with the fourth and fifth metatarsal, whereas cuneiform 1 articulates with the first metatarsal, cuneiform 2 with the second metatarsal, cuneiform 3 with the third metatarsal. So 1, 2, 3, 4, 5, these are the metatarsals. Like in the hand we had carpals and metacarpals. In the foot, we have tarsals and metatarsals. And then distal to that, we have our phalanges. Same setup as the hand. There's a proximal, a middle, and a distal phalange for toes 2, 3, 4, and 5. They all have a proximal, a middle, and a distal phalange or phalanx. However, the great toe, just like the thumb, only has a proximal. This should say proximal, not proxima. So it's proximal phalanx or phalange and distal phalanx or phalange. And remember, the great toe is also known as the hallux. When we look at it from the lateral, from the medial view, because this is the great toe, we can see there's a nice arch. There's a longitudinal arch. And there's muscles that go along here on the plantar surface. And sometimes the group of muscles is called the plantar fascia. The tighter that fascia is, the higher the arc. The looser the fascia is, the more flat-footed you become. High arcs are called pes cavis, and flat feet are called pes planus. Sometimes, especially in runners, when that plantar fascia becomes really, really tight, it pulls from the calcaneus to the toes, and you get this higher arc. When it pulls and pulls and pulls, especially on its site of origin, which is on the calcaneus, you can get the bone that tugs away. You can get the calcaneus starts to create this little spur that comes off of it called a calcaneal heel spur. And this becomes very, very painful, especially when people take that first step out of bed and their heel hits a hard surface like a tiled floor. It becomes very, very painful. It's called a calcaneal heel spur or an osteophyte. Again, on the toes, so these are the 7 tarsals. Then you have metatarsals, and then you have your phalanges. And remember, the hallux only has a proximal and a distal phalange, whereas the other toes have a proximal, middle, and distal phalange. And that's just a close-up view of the foot to get a closer look at those 7 tarsals. Remember, in the hand, you had 8 carpals. In the foot, 7 tarsals. Again, you had the talus, calcaneus, navicular, cuneiform 1, 2, and 3, plus the cuboid. 5 metatarsals, metatarsal 1, metatarsal 2, 3, 4, and 5. So if you're asked on an exam, what is this? You can't just say metatarsal. You would say second, like 2ND, second metatarsal, or metatarsal 2. If you're pointing to here, you would say second proximal phalange. Okay. And again, from the inside, here is the talus, the highest bone. Here's the calcaneus, which is your heel bone. On the inside, you could see the navicular and the first cuneiform, which is the medial cuneiform. First cuneiform articulates with the first metatarsal, and then proximal and distal phalange. Okay, let me stop the screen share here, and I'll be more than happy to handle any questions.